Good evening and welcome to another session of vlogs from UKDG. Today we are here to discuss MASLD, which is basically metabolic associated steatoliver disease, which is essentially the common fatty liver that we see in our day to day life. Not only doctors, I think patients today are pretty much aware that their liver collects fat when there's fat around the tummy. And everybody wants to know, not the nation, but everybody wants to know what is happening to the liver with this fat. To tell us more about it, we have Dr. Debasis Datta, consultant gastroenterologist and hepatologist, one of the founding members of East Kolkata Diabetes Group, and Dr. Samit Ghosal, consultant physician and diabetologist, who's also one of the founding members of the East Kolkata Diabetes Group. So, Dr. Datta, I'll kick the ball straight to you. The topic says what your liver wants you to know. What exactly is the liver wanting to know from us?
So, you have probably all heard of this term called fatty liver. So, if I can say, MASLD is also one of a fancy name of fatty liver, because it is not only the liver which is affected, but it affects a lot of other organs. So that's why it's called metabolic associated steatotic liver disease. So previously, you used to know of a term called non-alcoholic fatty liver disease, where people who did not drink significant alcohol, if they have any liver issues, it is to be called non-alcoholic fatty liver disease. Now the terminology has changed to MASLD. Now it encompasses a lot of things. Why are we worried? Because a lot of people do have fatty liver, but a small proportion of them may develop inflammation of the liver due to the fat, which can in future lead to liver damage, i.e. cirrhosis of the liver, which may in turn lead to liver cancer. So we need to be very cautious about anyone with a diagnosis of fatty liver to see if they need any treatment to prevent it from going any further to liver inflammation or cirrhosis. And also one thing to remember, Binayak, is fatty liver is not an isolated condition. So if anyone has got a fatty liver, they may have other conditions like diabetes, problem with their cholesterol, triglyceride levels, even problem with their heart or kidneys. So it's not a single entity. We actually have to look at other conditions which are associated with it.
So,
I think the Dr. Sinha's screen just got frozen. Hello?
can you hear me now?
Yes, we can hear you now.
Right. So, talking of diabetes and hypertension and dyslipidemia, so what percentage of your patients, Shomit, do you see with MASLD in your clinical practice, which essentially looks after diabetic and dyslipidemic patients?
Thank you, Binayak. At the outset, Jai Hind. And in this situation, I think it's appropriate that I start with that. Secondly, I think as a practitioner, we sometimes miss or we do not do an audit of our prescription and find out what percentage is happening. But I think very recently, Dr. Datta, myself, and Dr. Shishadri from Chennai, we pulled our data. And we got a prevalence in the type 2 diabetic population of around 53.9%, or approximately 53%. And I went ahead with the Indian
Huge.
Association, the Indian guidelines, and the global guideline says that the 38% is the MASLD overall. And the minute you bring in type 2 diabetes, nearly half of your patients have MASLD. So that's a huge number we're talking about, right?
I think majority of the patients with diabetes, I feel, Shomit, needs to be screened for fatty liver. I think we never used to do that previously. But anyone who presents with diabetes or even dyslipidemia, that means high cholesterol, triglyceride, will probably should be screened for fatty liver disease, because early diagnosis is quite important.
I agree, because I think the new 2025 guideline that all type diabetic patient needs to be screened for MASLD. Those who are non-diabetic, you may screen them if they have more than equal to one other additional risk factors. But type 2 diabetes per se needs to be screened.
So,
Yes, Vinayak.
I think the
I think
automatic
there's a
question that Dr. Datta, which comes up, that we are acknowledging that that MASLD is there in a very large proportion of patients who are diabetic, but more so people who are actually not diseased. They are overweight to obese and do not have any other diseases. Now they actually do not come to us. They are there in the community and they are living with. I think we are just treating or screening the tip of the iceberg. I think the large majority is out there who just have obesity, and which itself is an independent risk factor for MASLD. So I think we need more public, health care messages to go out that
I think
if you're overweight or obese, you need to be get screened for it also.
I think any obese patients, now the definition of obesity is also changing, as you will say, Shomit. Anything who we say is obese, I would actually go anyone with a BMI probably above 25. Previously used to be have 30. I think they should have a health screening. It's not only for the liver. I think they should screen for diabetes, cholesterol, and check for hypertension, kidney diseases. I think the screening is very important because many of these patients have undiagnosed disease, not only with the liver, but also possibly hypertension, possibly other factors. And I think it's, as you said, it's just a tip of the iceberg. We are missing a lot of patients with liver issues, and they suddenly present to our clinic with the diagnosis of cirrhosis. But if you could diagnose them early, then this can be prevented. Binayak, you are back.
I'd like to take you both up on this question of 55 your patients have chronic liver or fatty liver or MASLD by definition. So, what are we looking at? Epidemic of cirrhosis or an epidemic of liver cancer?
Can I take this one, Shomit? So, you see, what Shomit is saying is 55% of them has got MASL. That doesn't mean all of them have got cirrhosis. So cirrhosis doesn't happen in one day. Cirrhosis is an irreversible condition in the liver, and which is quite serious. But what happens is it goes through different phases. So if someone has a fatty liver diagnosis now in an early disease, for someone to have cirrhosis will take many years. We're talking about 10, 15 years. So it goes to different phases. So what we say is initially it is F0, so there is no fibrosis in the liver. Then they will turn to F1, mild inflammation. F2, which is start of fibrosis. F3, F4, and then we have cirrhosis. So what we are talking about is 55%. All of them don't have cirrhosis. They are in the different brackets. Some are F0, some are F1, 2, 3, some are cirrhotic. So our aim is to try and diagnose the patients who are early stages like F0, F1, F2, so we can give treatment so that there is a reversal of fibrosis. So they don't progress to cirrhosis, but actually go back to the F0 category. So all 55% are not cirrhotics. The second point is you're absolutely right. We are actually sitting sort of on a really, really sort of slippery slope in the sense that there are many patients who are actually not diagnosed with fatty liver or MASLD, and they will suddenly turn up with cirrhosis because we have to remember the initial disease of fatty liver has got no symptoms. So people do not know they have got fatty liver unless they have done the tests. So that is the problem. So if someone knows that I have got abdominal pain and I'll get fatty liver, that's not true. The initial phases of fatty liver are all silent disease, and that's the problem. And that's why we need to screen and make sure they haven't got any advanced disease.
So, Shomit, how do you screen your patients with diabetes for fatty liver disease? Is there any protocol?
So you see, one thing that I've ensured over the years is that every patient getting an LFT done must have a platelet count along with it. just looking at SGO-TPT might lead to under as well as overdiagnosis. Because the platelet count, which is the denominator of that equation of the fibrosis 4 score, is the game changer. And so one thing I screen all my patients, because nowadays a lot of them come with this bunch of reports where anyways they have a CBC and the platelet count, and the SGO-TPT will be there. And with the Medcal calculator, I just do the FIB score. Here comes an important part. Again, I want to go back to Didi, if you might permit me to, which is that we follow guidelines like the American Diabetic Association or European guidelines tells us to use a cutoff of 1.3 of FIB score to further screen our patients or plan treatment for our patients based on the advanced testing. Now, the Indian guideline is telling us that the cutoff is 1, it is not 1.3. That improves the sensitivity of the test, but the specificity goes down, which means there are a lot of false positive. Now, we are seeing even with 1.3 in clinical practice, large number of patients we are sending for the transient elastography testing. A large number of them are coming back with F0. Now, are we now going into an over investigation, or of these 53% patients that we are talking about, are we just over investigating them? That becomes a very, very big issue. We need to settle, I think, this cutoff value. As we were talking about a Mishti study, we found 1.5 as an adequate cutoff value, and different, cross-sectional studies have found different values to match the sensitivity and specificity. What I think, what Didida and us, when we were writing the manuscript, which we pointed out is, if you have a clinical suspicion, someone is obese, have type 2 diabetes, but even if the FIB score is normal, if there's a clinical suspicion, we should go ahead with advanced testing. Someone who is just, having a FIB score which is more than 1 or 1.3 has no additional risk factors. Probably we need to follow them up and not, jump to the further testing. So this is a very important area. Because if you do not have, if you do not use a proper screening method, we miss, as Didida said, a lot of patients in early F1, F2, or we over investigate them. So Didida, how exactly for the Indian subset of patient, which cutoff do we use? Because we sometimes physician get confused with 1.31, the cutoff given to us by different guidelines.
So my view is slightly different in the sense, in India, a big factor is an affordability issue. So we have to accept that. So if a patient cannot afford, I think FIB4 is still quite valid. I think you're absolutely right. The cutoff, whether it's 1.3, 1.5, 1, it's up to anyone's judgment. If there is a doubt, I will also look at the bilirubin and albumin level. If the albumin level is low, there is suggestion there might be a problem with the liver. Now, what I do, if the patient can afford, and if there's any confusion, FIB4 score, there is a confusion if the score is between 1.3 to 2.67. So we do not know where the patient is. I will always ask for a transient elastography or an MR elastography, which are two tests to look at the liver stiffness. Previously, we had to do liver biopsy. Nowadays, we don't do it unless in extreme cases. And there have been multiple studies to standardize the transient elastography and the MR elastography, suggesting which stage of fibrosis the patient is. So whether it's F0, 1, 2, or 3, or 4. Now, one simple problem we are facing in Kolkata is there are many centers, there are different instruments of transient elastography, and I do not think all of them are standardized, and a lot of people are doing free testing also. So I think we need to have a standard protocol, sort of which machines and what we are using to do these tests. MRI is very good, but again, there aren't many places who are doing MR elastography. So I think we have to look at which center where we are working and using it suitably. FIB4, I won't write it off because I think it is quite relevant for some patients. And but again, if there is confusion, you should do another second test. That's my suggestion.
Are you writing off ultrasounds?
No, of course not. Ultrasound is always will be the first test to do. Why? It's actually probably not showing you how much fibrosis there is, but it actually tells you also a liver architecture, whether there is any nodular liver, whether the liver is shrunken, which also actually points towards cirrhosis. And more importantly, ultrasound will pick up, a good ultrasound will pick up small focal lesions, which might be an early cancer. And ultrasound is an excellent, cheap, good test, which should be done on the first line. And it not only gives you the information of the liver, it will give you information of other things also. So ultrasound is always the first line. And if the ultrasound suggests fatty liver, or as you're doing FIB4, you go for the second line like transcranial elastography or an MR.
So
I
I think
agree,
we've
Binayak. I think the Indian guideline starts off with the ultrasound, which we don't find in the other guidelines. But the Indian guideline is very specific. It writes that you start off with an ultrasound.
that's pretty sensible, actually. I
Yes.
think if it's so, I think we've discussed the diagnosis and screening for MASLD. The question now comes: how does one stop this fatty liver or MASLD from developing? Didida.
I think it's a lifestyle. You see, as I said, there is a lot of data on how to diagnose and how to do it. And as I said, there are a lot of patients who are not diagnosed. So I think the lifestyle is important. Whatever studies you look at, the people who are more prone to have fatty liver. I'm not talking about alcoholic liver disease. I'm just talking about people who do not drink excess alcohol. Fatty liver, or MASLD, what we call, the people are usually overweight. People usually have sedentary lifestyle, or people have comorbidities like diabetes, high blood pressure, dyslipidemia, as we were just discussing. So I think lifestyle is very important. Diet, exercise, and healthy eating. I think that's something which can prevent fatty liver.
Is alcohol banned?
Sorry, I missed that.
So
Is alcohol?
Banned.
banned.
No, no, no. Alcohol is not banned at all. I don't think there are multiple guidelines which actually shows that unless someone is drinking excess alcohol, it should not matter. But you see, the problem is we do not know how a person will react to an alcohol. So there are people who won't drink heavily but still have liver disease, and some will drink heavily, won't have liver disease. So alcohol is not banned, but sensible alcohol drinking is important. And I think there are a lot of data about how much alcohol one can drink. Most of them are Western data. Indian data not that much, but now the guidelines have come that for female 20 grams a day, and for male 30 grams a day. Less than that is a permissible limit. So one drink for ladies, two drinks for men. That's what is coming to. So no, alcohol is not banned, but someone has to be very sensible. About alcohol drinking.
Shomit, I'll move on to a little bit more on the management. Anti-diabetics have taken a center stage in management of MASLD or MASH, whatever you would want to call it. So, could you take us through the drugs that have come into focus as far as MASLD is concerned, namely pioglitazone, SGLT2, and of course GLP-1 receptor analogs?
Yes. I think I'll start off from where Didida left off, which is it's a heterogeneous disease, and there are three clusters we need to remember when we talk of MASLD. One is a genetic defect at the level of the liver, where the fat is accumulating in the liver but doesn't go to the bloodstream. Now, this is a cohort who the individuals who have a high risk of liver-related complications but have very low risk of cardiovascular disease. Now, this is a specific entity. Second entity is those who synthesize their own fat in their own liver and throws the fat also into the bloodstream. Now, they are at a very high risk of cardiovascular complications. What you need to understand that this trigger of the fat generation in the liver starts due to lifestyle, increase in sucrose, increase in fructose-rich meal, increase in saturated fat. That causes the insulin resistance and throws the excess fat. Now, these are the ones who accumulate fat all over the body. They develop sleep apnea because they accumulate fat in the respiratory system. They develop liver disease. They develop chronic kidney disease, dementia, and all those things. So, an holistic approach in reducing their weight needs to be done. Third, we also found from our cohort is a very important entity called lean MASLD. Lean means BMI is less than 23. Here, weight management is not that important. These are the individuals where adipose tissues outside the body is creating this excess fat and sending it into the system. Now, this third category, the lean MSLD, is where pioglitazone comes in, because this is where we need to accumulate the internal fat stores. They need to be restored, and that's exactly what pioglitazone does. Now, the second category, which was due to the liver de novo synthesis of fat is happening and throwing into the system, comes in GLP-1. Now, GLP-1 is the one we have been using for weight loss and sugar control for a long period of time, especially the drug which was sort of a prototype we brought in also cardiovascular outcomes reduction was liraglutide. Liraglutide was subsequently even was approved for weight reduction at 3 milligrams. Now we are finding excellent data with semaglutide, the next generation. The oral semaglutide is available with us, and we're hearing very soon the injectable one will also be available. Now, if you want to burn more amount of fat and energy, remember resolution of the fibrosis stage will happen once you start losing more than 10% of your baseline body weight, which the usual SGLT2s and the GLP-1s won't help us achieve that level. So there comes the dual agonist, the GLP-1 GIP, which has been launched very recently. New oral formulations or forglipron is also, a hot property now. Triple agonist, bringing in glucagon is also in the pipeline. And they are getting approval for MSLD treatment, as you rightly said, not only for diabetes, but because they do not cause hypoglycemia, they are also being approved for the non-diabetic setup. So they can be used, but we need to remember that their effect is from the metabolic perspective. Their impact is not necessarily at the level of the liver. That is a different group of drug. Probably you'll put the question to Didida, which are specific to the liver outcomes. These reduces fat, reduces the impact on the liver, and reduces cardiovascular, outcomes. It gives all those benefits, cardiovascular benefits.
Shobit, I'll stay with you on this for a little while longer, and I'll ask you. So, what about the 3 milligrams of liraglutide and the 2.4 milligrams of semaglutide? Do you think they will make a significant difference?
Yes, definitely, definitely. 3 milligrams data, the lean study and other studies are excellent data done specifically on, rather the only two biopsy driven study done was with SEMA and with liraglutide. So liraglutide
That's
has a biopsy proven study and probably we might have generic 3 milligrams coming very soon. So it would also be cost effective compared
right.
to a semaglutide that we have.
Right. So these are all anti-diabetics, Didida. What about drugs that are specific to the liver? We've heard about vitamin E. We've heard about this our obeticholic acid and our very own Make in India saroglitazar. Can you give us a brief overview of all these three drugs?
You see, the first thing is I will mention that whatever studies have been done, the every study includes two things: exercise and diet. So we can add many medications, and I think from the diabetes point of view, metabolic point of view, there have been fantastic medications which are coming in, which are beneficial. But I would like to reiterate, exercise, diet is very important. And there have been very good studies showing that if someone can lose 10% of their weight, there's
There's
actually
regression.
reversal of some fibrosis. So I think we should not we should give a lot of importance and tell the patients that doing the exercise, having proper diet, we can have a long discussion about diet. Losing weight is very important. Now, regarding the drugs, you see, first of all, I used to like obeticholic acid quite well, but it has gone quite completely out of fashion. There have been some river-related issues, so we are not using, unfortunately, obeticholic acid anymore. It came up at a big hype, but I think most hepatologists have stopped using it. Saroglitazar, yes, there have been few studies which have come up showing it is actually beneficial in certain patients, especially with obesity, high triglyceride levels. And Indian Society of Gastroenterology and INASL, which is the liver society, has actually recommended saroglitazar in MASLD. But I must mention, this is not for cirrhosis. So saroglitazar is recommended for F1 to F3 fibrosis, not for F4 or beyond where the patient is cirrhotic already. So there is always confusion. I see patients with cirrhosis on saroglitazar. There is no evidence till date that in cirrhotics saroglitazar works. And the third one is Evian. I think it has been there for a while. There have been big studies about it. That is vitamin E, and it is quite safe. There was slight concern about prostatic cancer, but I think many meta-analysis has shown that the risk is probably not that high. So these are the three drugs. So nowadays, if we see F1 to F3, most of us will use Saro and plus minus vitamin E.
Right. What about the very famous ursodeoxycholic acid?
Ursodeoxycholic acid actually does not reverse fibrosis. I think it's very
What about
important to
fatty liver?
understand.
Does it
No,
help in any way in fatty liver?
it doesn't help in fatty liver, but what it helps is it improves the liver function test, improves the cholestasis, and that makes both the doctor and the patient happy. But it actually has no role in reversing fibrosis in MASLD.
Right. So it's finally come down to
Things finally come down to lifestyle
I know.
modification.
So it's finally come down to lifestyle and being a good boy. And if you are really a diabetic, you can. If you're lean, you go for a pioglitazone, and if not, then you go for a GLP-1 or a twin cretin, or go for a triple agonist or an oral GLP-1 or something like that. If you do not have diabetes, you can go for these drugs, but you probably can go for drugs like vitamin E and saroglitazar. Though I think, from what Dr. Datta said, saroglitazar has to be used with care because it is not something that you use in established cirrhosis, something that we see being practiced on a day to day basis, which we should avoid. So, finally, before we leave, we've got people who are watching who are not really doctors. These are people who are laypersons, um, who want to know about the liver and how to keep the liver healthy. I will give each of you 1 minute to tell us your thoughts about the way to a healthy liver.
If I may start, it's only two words: exercise and diet. And I always recommend to my patients to keep a weighing machine at home. If your weight is going up significantly, watch it, and I think be careful about it. And also, if it's going down significantly, you need to watch it also. So it's quite important to keep an eye on the weight. You don't need to do fancy tests. If you are not feeling well, that's a different thing. Keep an eye on your weight, and there is, if there are any risk factors like obesity, family history, do get to do a blood test, a routine blood test, just a liver function test to see how things are.
But before I leave you, there's also this question of cholesterol that you had brought in, and I'm sorry I had to bring it in at the last instance. So, if somebody has fatty liver, do we treat them with statins, or do we
Yes,
stop those
yes.
medicines?
I think there is absolutely no reason not to treat them with statins.
So, statins are in, and they actually would help reduce the
Absolutely.
liver
I think
fat as well, wouldn't?
there is a false concept that with a liver abnormality you cannot use statin. Yes, there are certain patients who won't tolerate statin, but the number is not high. I think we got to use statins. It's a very standard practice that we got to use statins in liver disease with dyslipidemia especially.
Shomit, as a diabetologist, your last words on this metabolic scourge.
So for physicians at large, please screen for NFLD for all your type 2 diabetic patients. Uh, that is a thing that we should not miss because this prevalence is quite big. From the overall general public perspective, as Dirida said, don't think you're safe simply because you don't have any other metabolic disorders. If the weighing scales or your hip, the size of your belt is going up, definitely screen yourself for ectopic fat accumulation and get a routine test done of at least annually if possible.
Thank you so much, Dr. Datta, Dr. Ghoshal. You've been wonderful panelists. I'm sorry I had a bit of a glitch in the middle. And thank you, ladies and gentlemen, for being such a wonderful audience. I'm sure you've learned a lot because I personally have. Thank you, stay well, and Jai Hind.
Thank you.
Thank you very
Thank you.
much.